Imagine taking a drug that completely halts a debilitating neurological disease.
Right.
And it actually restores the physical mobility that you thought you had lost forever.
Mm-hmm.
But then, like 5 years later, you're sitting on your couch, totally free of those initial symptoms, and your immune system suddenly begins this fatal attack on your own blood platelets.
Yeah, it's terrifying.
Welcome to the deep dive. Today, we are acting as your consultation team. We're examining a really comprehensive clinical review of Alemtuzumab.
It is arguably one of the most powerful disease-modifying therapies we possess for relapsing-remitting multiple sclerosis, or RRMS.
Right.
And it forces both clinicians and patients to make an incredibly difficult calculation.
Because it's a huge trade-off, right?
Exactly. We're evaluating a biological intervention that offers dramatic, almost unprecedented clinical benefits.
Oh, absolutely unprecedented.
But those benefits are tethered to a safety profile that is so volatile and honestly complex that it demands years of hypervigilance.
Yeah. So for those of you listening, whether you're a neurologist, actively weighing these extreme options for a patient, or a medical student looking at the absolute cutting edge of pharmacology, or just someone fascinated by how far we can push the human body, we are going to break down how medical science balances this incredible biological power against the strict reality of risk management.
And to understand that balance, we really have to look objectively at what this drug actually achieves in the clinic.
Okay, let's unpack this, because the numbers are wild.
They are. We're looking at efficacy data from 3 pivotal trials here. There's CARMS 233, which was phase 2, along with CARMS-I and CARMS-2.
And the baseline for these trials is super important, right? Because they didn't just test Alemtuzumab against a placebo.
Right, no, they tested it against an established standard of care active treatment.
Which was subcutaneous interferon beta 1A.
Exactly.
And, beating a placebo is one thing, but proving absolute superiority over an active disease-modifying therapy that sets a much higher bar.
It really does.
And the data shows it didn't just clear that bar, it essentially rewrote the expectations for RRMS treatment. Like, let's look at the CAMS 223 trial.
Right.
This focused on treatment-naive patients.
Right.
People with early active disease. And the data showed a 74% reduction in the risk of relapse compared to interferon beta 1A.
Which is staggering.
It is.
Yeah.
To put a 74% reduction in perspective, if a patient is statistically expected to suffer, say, 4 relapses over a few years, and these are relapses that systematically steal their mobility piece by piece, this drug essentially cancels 3 of them. It fundamentally alters the trajectory of their life.
It does. It completely changes the game. And we see that high-impact efficacy persist even when the clinical scenario becomes significantly more challenging.
Right, like in CARMS 2 trial.
Yes, if you look at the CARMS trial, this cohort consisted of patients who had already shown an inadequate response to prior therapies.
So these are people who are already failing on other drugs.
Exactly. These are individuals who had at least one breakthrough relapse while actively taking drugs like interferon beta or gledarim or acetate.
So the disease was already actively overpowering standard treatments.
Correct. And even in the escalation setting, Alemtuzumab demonstrated a 49.4% reduction in relapse rate compared to the active control.
Wow. Even when the disease is that aggressive.
Yeah. But reducing relapses is really only half the story here. The more profound metric is its impact on the sustained accumulation of disability, or SAD.
Right, the SAD scores. This is where the clinical profile becomes truly unique.
It really is.
Because in CARMS 2, Alemtuzumab showed a 42% risk reduction in sustained accumulation of disability. But it goes beyond just freezing the disease in place, right?
Okay.
Standard medical logic tells us that once nerve damage occurs in MS, it's permanent.
That's always been the assumption.
Yet the post-hoc data actually showed an improvement in pre-existing disability scores.
Yes, actual reversal.
Patients were seeing measurable improvements in the Expanded Disability Status Scale, the EDSS, across all 7 functional domains. And they were also improving on the 9-hole peg test, which
measures fine motor coordination in the hands and arms.
Exactly.
And seeing patients regain upper extremity function that they thought was lost to the disease forever, that signals a shift from simply managing symptoms to fundamentally altering the underlying pathophysiology.
Right, but if the disability is actively reversing, standard medical intuition would suggest, the patient must be heavily saturated with this drug 24 hours a day, 7 days a week.
You would think so.
But the dosing schedule defies that completely. The patient receives an intravenous infusion for 5 consecutive days. And then they go home.
Just go home.
12 months later, they return for just 3 consecutive days of infusions. That is 8 days of active drug administration spread across 2 full years.
It is a radical departure from the daily pills or, the weekly injections that usually characterize chronic disease management.
Which raises the obvious question about the mechanism. I mean, we know in RMS, autoreactive T and B cells mistakenly cross the blood-brain barrier, and they attack the myelin sheath protecting the nerves. And Alemtuzumab is an antibody that targets the CD52 antigen.
Right.
But if we are completely wiping out the circulating T and B lymphocytes with this CD52 targeted antibody, why does the clinical benefit, the sustained remission, outlast the physical presence of the drug in the body by several years?
What's fascinating here is that it comes down to the precise selectivity of that CD52 target.
Okay.
So CD52 is highly expressed on mature T and B cells. When alemtuzumab binds to it, it essentially flags those mature cells for destruction by the body's own immune system.
Right, it marks them.
Exactly. But crucially, hematopoietic stem cells in the bone marrow, they do not express CD52.
Oh.
Yeah, and the innate immune system is largely spared as well.
I see. So it's not a blind carpet bombing of the entire immune system.
No, not at all.
It's more like uninstalling a corrupted software update, those autoreactive mature cells, while leaving the core operating system and the hard drive completely intact to just reboot fresh.
That is an excellent way to conceptualize it. It is a biological reboot.
Wow.
When those lymphocytes eventually repopulate from the bone marrow and the thymus, they seem to emerge with a different, much less autoreactive profile.
That's incredible.
It is. The environment is reset and the immune tolerance is basically restored. This is why in the extension studies, over half of the patients from the pivotal trials didn't even require a third treatment cycle over a 6-year period.
Over 6 years. And they were just fine.
Yeah, they maintained stable or even improved disability levels. The software, booted up correctly.
But of course, the terrifying flip side of a system reboot is what happens when that new software boots up with a completely different set of glitches.
Yes.
Which creates this seamless structural link between how the drug works and its most severe clinical risk, secondary autoimmunity.
This is the double-edged sword of immune repopulation. The gradual return of those lymphocytes that grants the patient long-term remission from their MS, that is the exact mechanism that can inadvertently trigger entirely new autoimmune diseases.
Right.
And the timing of this risk is so insidious.
Because it doesn't happen while they're in the clinic receiving the IV.
No.
The peak risk window for these secondary autoimmune events sits somewhere between 6 to 60 months after the infusion cycle.
Yes, months to years later. And we think this occurs because different immune cells repopulate at completely different rates.
Oh, they don't come back all at once?
No, B cells tend to bounce back much faster than regulatory T cells, and regulatory T cells are essentially the adult supervisors of the immune system. They keep other cells from, attacking healthy tissue.
Right.
So during that months to years long window where B cells are active but regulatory T cells are still low, the B cells can just go rogue without supervision.
Creating new autoimmune targets.
Precisely.
And the most frequent target by far is the thyroid.
Yeah.
In the 5-year follow-up of the CAMS 223 trial, thyroid disorders were observed in up to 39% of treated patients.
Almost 40%.
We are talking about hyperthyroidism like Graves' disease or hypothyroidism. 4 out of 10 patients developing a completely new organ disorder is a staggering incidence rate.
It is a massive number. However, from a strictly clinical perspective, thyroid disease is highly manageable with standard endocrinology protocols.
Just take a pill.
Right. The much deeper concern lies in the rarer, significantly more dangerous autoimmune responses, like immune thrombocytopenic purpura, or ITP, which occurs in about 1% to 3% of patients.
And this is where the newly repopulated immune system starts destroying blood platelets, right? Stripping the blood of its ability to clot.
Exactly. It leads to severe bruising, internal bleeding, and if it's unmanaged, it can lead to life-threatening hemorrhages.
God.
You also see cases of anti-glomerular basement membrane disease, or anti-GBM disease.
Which is kidney failure, essentially.
Yes, that's where the immune system attacks the filtering units of the kidneys, rapidly leading to renal failure. Goodpasture's syndrome.
I have to highlight the profound paradox of this clinical scenario.
It's intense.
We are treating a patient for an autoimmune disease. The treatment is so effective, it can literally restore their mobility. But the treatment itself can trigger a different, potentially fatal autoimmune disease.
Yes.
Like the review explicitly cites a patient in the CAMS 223 trial who developed ITP and tragically died from an intracranial hemorrhage.
It's devastating.
How do you, sitting across from a patient, justify a clinical profile that includes a risk of fatal secondary autoimmunity?
You justify it through a brutally honest assessment of the alternative.
Okay.
You cannot evaluate the risks of Alemtuzumab in a vacuum. You just can't. You must weigh them against the absolute certainty of aggressive disease progression.
Right.
Active RMS that is breaking through standard therapies will relentlessly rob a patient of their mobility, their independence, and their cognitive function. Untreated, it is a devastating, guaranteed decline.
You are weighing a guaranteed slow devastation against a rare but severe acute risk.
That is the calculation.
Yeah.
But you don't just accept the risk blindly, you manage it through obsessive vigilance. You essentially tell the patient, we have the tool to stop your MS, but the cost of that remission is that we must monitor your blood and organ function relentlessly for the next half decade to ensure your immune system behaves.
Yeah. But before we even reach that long-term monitoring window, we have to look at what happens in the immediate aftermath of the infusion.
Right.
If the secondary autoimmunity happens months or years later when the immune system repopulates, what happens in those first few days and weeks when the matured T and B cells have just been actively wiped out?
Well, the very first hurdle is infusion-associated reactions, or IRRs. These affect more than 90% of patients.
Almost everybody.
Pretty much. When you rapidly destroy that many immune cells, they release a massive amount of cytokines into the bloodstream. This causes everything from severe headaches and rashes to pyrexia, meaning high fever, and in rare cases, anaphylaxis or cardiac arrhythmias.
Though the protocol does require pre-medicating the patient, right, with high-dose corticosteroids to blunt that cytokine release.
Yes, exactly.
So those reactions, while uncomfortable, are an expected acute hurdle. Here's where it gets really interesting, though. It's like leaving the castle gates unguarded while the army is away.
Great analogy.
Because the much more complex vulnerability during this immediate post-infusion window is opportunistic infection. By drastically reducing the circulating T and B cells, you've temporarily removed the primary defenders against pathogens.
You have. Now, the overall incidence of serious infections is actually quite low, between 2% to 4% in the pivotal trials, largely because that innate immune system we discussed earlier is spared.
Right, the neutrophils and macrophages are still patrolling.
Exactly. However, certain specific pathogens take distinct advantage of the missing T cells. We see significantly increased rates of upper and lower respiratory tract infections, and specifically herpes viruses.
Right, and the clinical review detailed a couple of incredibly striking case studies regarding Listeria meningitis, which perfectly illustrate how fast these opportunistic infections can take hold. I was reading the case of the 47-year-old female patient. She developed a severe headache the exact day after her 5th infusion.
Just 24 hours later.
Yeah. And by day 3, her fever spiked to 104 degrees Fahrenheit.
And what's remarkable about that case is how quickly her neurological symptoms worsened alongside the infection. Because her T cell defense was down, the Listeria bacteria didn't just cause mild food poisoning.
Yeah.
It crossed into the central nervous system. They cultured her cerebrospinal fluid, confirmed Listeria monocytogenes, and she required a rigorous 21-day course of intravenous ampicillin to clear it.
21 days of 5E antibiotics.
Yeah.
And there was a second case that followed almost the exact same timeline. A 43-year-old female, 3 days after her final infusion, spikes a fever of 104.7 degrees. She develops an agonizing headache, a stiff neck, and extreme sensitivity to light. A lumbar puncture confirmed Listeria again, requiring 3 weeks of heavy intravenous antibiotics to resolve.
Both patients fully recovered, thankfully, but it sharply underscores how aggressive these pathogens become without T cell suppression.
Given these specific vulnerabilities, how do we practically protect the patient during this window? Because I was stunned reading the preventative protocols for this, because medicine essentially becomes dietary.
It does.
Since Listeria is a foodborne pathogen, the intervention is simply restricting what the patient eats.
That is the stark reality of severe immunosuppression. Patients must absolutely avoid unpasteurized milk and raw or undercooked meat during the treatment and for at least a month afterward.
Wow.
When your adaptive immune system is depleted, a seemingly mundane choice like eating a slice of raw milk cheese or a rare steak can be the literal difference between normal recovery and a 104-degree fever with meningitis.
That's terrifying. And for the herpes viruses, you obviously can't control that with diet.
No, you can't. So for the herpes viruses, patients are placed on oral anti-herpes agents starting on the very first day of the infusion and continuing for an entire month after each treatment cycle.
Just blanket coverage.
Exactly. Additionally, female patients require annual screening for human papillomavirus, or HPV, due to the increased risk of severe cervical infections while the immune system is rebuilding.
Okay, so what does this all mean? Synthesizing all of this data,
Yeah.
we have a biological agent that practically stops RRMS in its tracks.
Yes.
It occasionally reverses physical disability,
True.
and it requires only 8 days of active infusion over 2 years. Yet it can cause severe thyroid disease, trigger fatal bleeding disorders, and leaves a patient wide open to brain infections from undercooked food.
Yeah.
How does modern medicine practically operationalize a drug with this extreme of a profile? I mean, what are the clinical guardrails?
It requires an incredibly rigid, mandatory infrastructure. A physician cannot simply write a prescription for Alemtuzumab and tell the patient to come back in a year. The FDA and EMA mandate a comprehensive risk management plan, often called a RRMS program.
And this isn't a strong suggestion, right? It's a legal and clinical requirement to even prescribe the drug.
It is absolute. If you don't comply, you don't get the drug. And the core of this program is the monitoring timeline. Because the secondary autoimmunity risks peak months or years after the drug is administered, the monitoring period lasts for 48 months following the very last infusion.
4 full years of testing.
Yes.
After the drug is completely out of their system. What exactly is the patient committing to month after month?
The patient is committing to monthly complete blood counts with differential. The goal there is to catch the early asymptomatic drops in platelets that signal ITP.
Okay.
They're committing to monthly serum creatinine tests and urinalysis to watch for anti-GBM disease or other kidney failures
Every single month.
every month. And they're taking thyroid function tests every 3 months.
That is an exhausting clinical burden for both the physician and the patient. You are tying the patient to a laboratory for half a decade.
You really are.
The anxiety of waiting for those blood test results every 30 days must be immense.
The psychological toll is very real, but it is the only mechanism that makes the drug viable. If you catch ITP early on a blood test, before the patient starts bruising or bleeding internally, it is highly treatable. If you catch the thyroid dysfunction early, it is easily managed with oral medication. The danger with Alemtuzumab isn't necessarily the adverse events themselves. The lethal danger is an unmonitored adverse event.
Which makes patient selection incredibly crucial. You can't prescribe this to someone who has a history of skipping doctor's visits.
Absolutely not.
Or someone who lacks reliable transportation to a lab.
Logistical compliance is just one piece of the puzzle, though. The biological selection of the patient is where clinicians are currently struggling the most. We know the exact risks, but we don't know precisely who will suffer them.
Right, the review mentioned a search for biomarkers to solve this. They looked at interleukin-21, didn't they?
They did. Elevated IL-21 was proposed as a potential predictive biomarker to identify which patients would eventually develop secondary autoimmunity.
But it didn't work.
Unfortunately, no. The detection tests haven't proven reliable enough for practical clinical use. We simply do not have a blood test that says, this patient will reboot safely, but this patient will develop kidney failure.
That's rough. So what do you rely on in the absence of a biomarker?
You rely on meticulous clinical history and extreme caution. You look deeply at their family history of autoimmune diseases.
Okay.
You also look at how their body reacted to previous MS therapies. For example, the review notes cases where patients developed severe ITP and thyroid disease after Alemtuzumab. And upon reviewing their charts, these same patients had previously experienced severe lymphocytopenia, which is a dangerously low white blood cell count when taking a completely different drug like fingolimod.
So a previous volatile immune reaction to a completely different drug serves as a major red flag.
Yes.
It suggests their immune system is already primed for an unstable reaction to depletion therapies.
Precisely. The selection criteria are highly restrictive for that exact reason.
It really reframes the whole concept of prescribing. Treating RRMS with Alemtuzumab is not just dispensing a medication. You are entering into a multi-year, legally mandated clinical contract with that patient.
You are.
They are trading the immediate, devastating progression of their multiple sclerosis for the part-time job of being a closely monitored medical subject for the next 4 to 5 years.
That is the reality of the trade-off.
Let's bring this all together for you listening. We've explored a truly astonishing medical intervention today. Alemtuzumab represents a breakthrough ability to not just halt, but in some cases actively reverse the disability caused by active relapsing-remitting multiple sclerosis. It accomplishes this through a revolutionary annual dosing schedule, just a few days of infusions, that essentially reboot the immune system by selectively destroying mature autoreactive lymphocytes while sparing the underlying stem cells. But that profound efficacy is permanently chained to a volatile safety profile. The very mechanism that heals the repopulation of the immune system can trigger entirely new autoimmune diseases like thyroid disorders and potentially fatal ITP years down the line.
Yes.
And in the immediate term, it temporarily removes the defense against opportunistic infections like listeria. Therefore, utilizing this incredible biological power is entirely dependent on strict clinical vigilance, highly cautious patient selection, and an exhausting 48-month mandatory monitoring protocol.
It is a profound balance of risk and reward. But if we connect this to the bigger picture, the ability to selectively delete corrupted immune cells and allow the body to reboot its tolerance, it opens up a fascinating philosophical question for the future of medicine.
Oh.
We are currently using this reboot strategy to halt a specific neurological disease. But what happens if we master this process? What if we learn how to guide that repopulation perfectly without the risk of secondary autoimmunity?
That would be the holy grail.
Exactly. The real frontier isn't just creating a stronger immune-depleting drug. The real frontier is discovering that elusive predictive biomarker, a simple test that could tell us before the very first infusion whose immune system will reboot safely and whose will turn on itself. It suggests a future where rebooting your immune system might not just be a treatment for MS, but a foundational approach for erasing other unrelated systemic diseases, severe allergies, or perhaps even resetting the biological clocks tied to aging itself. Are we looking at a future where uninstalling and reinstalling our immune software becomes as common as replacing a joint? It's a concept that pushes the boundaries of how we view chronic illness entirely.